Good morning, and for those of you joining us, happy Valentine's. Welcome to the Joint Fiscal Committee on Valentine's Day after the snowy snow day. Would the secretary please call the roll?
Senators Buck, Canizaro, Dondero Loop, Neal, Wen, Stone, Taylor, Titus, Assembly Members Anderson, Backus, Brown May, Dickman, Hafen, Hibbets, Haudegi, Koenig, Mosca, O'Neill, Torres Fawcett, Watts, and Yeager. Chair Monroe Moreno.
And I am here. Will you please mark Assembly Member Watts and Assembly Member Torres Fawcett absent excused. I'll remind everyone to please silence your electronic devices. If you wish to testify, please sign in at the back table in the room in Las Vegas and here in Carson City. If you're joining us online, I ask that you mute your microphone until you're asked to speak. Members will be using their laptops to follow along with today's hearing. Please don't think that they're being rude, but they will be following along that way. We have a short agenda for today, and I see that the members of our agenda are already at the table. If you would like to do public comment to today's hearing, public comment will be at the end of today's meeting, and I'll give you the number now so you can get ready if you'd like to call in for public comment. The number is 888-475-4499. Today's meeting ID is 891-9671-8663, and then please press pound. Today we will have a budget hearing of PEB, which is our Public Employees Benefit Program, and I welcome you this morning, and again, happy Valentine's. You can start at any time.
Good morning. My name is Celestina Glover. I am the Executive Officer for the Public Employees Benefits Program, and with me today I have Michelle Whalen. She is the Chief Financial Officer, and Nick Prober, who is our Operations Officer. Today we have a slide deck for our GovRec budget, and I will take you through that. I will concentrate on a couple of areas and stop for questions as needed. Thank you. So, brief overview of our program. We take care of approximately 72,000 members. That includes 46,000 primaries and another 26,600 dependents. That's as of our January enrollment. We provide both state and non-state employees and retirees access to medical, pharmacy, vision and dental coverages through several plans. We have a high deductible plan, a statewide low deductible plan, and two regional plans, the EPO, which is the exclusive provider option, and the HMO. The EPO is for the group in the north, and the HMO is for the south. You have to be in those regions to be eligible to enroll in those specific plans. We offer the state and non-state Medicare retirees access to an individual Medicare marketplace. We call it the exchange, and there they can buy additional Advantage and supplemental plans. They also can enroll in PEB Dental should they choose to do so. Supplemental benefits are provided. This is a voluntary benefit, so during open enrollment, if members want to enroll in additional life insurance or home insurance, car insurance, pet insurance, vision plans, that is the option for them at that point. So back in 2021, the PEB board decided to take some actions. They put in place policies, which they can again change if they choose to do so, Underwriting the self-funded plans into a single risk pool. This is pretty standard for us. We've done this for years. Contribution strategy, so all the plans receive the same employer contribution. What we used to do in the past is we only had the HMO and the CDHP. So the CDHP being the primary plan, it was actually funded at a higher percentage, and the HMO was funded at a lower percentage. And part of the reason was to try to level set the out-of-pocket maximum for employees and retirees. Out-of-pocket maximum includes their premium that they pay and also whatever costs they bear outside of what the plan itself will pay. That decision was changed in 2021, so if the contribution is $500, it's $500 for every plan for a single person on that plan versus $500 for one, $600 for another, $700 for another. We also provide HSA and HRA funding. The HSA is on the high deductible plan. That's a health savings account. You must meet the IRS requirements for a health savings account in order to offer that. Health reimbursement arrangement is provided for retirees and those employees that don't qualify for the health savings account. The qualifications and the offering of that, as I said, is per IRS requirements. And then we streamlined the tier factors, and that was funding HSAs and HRAs for the primary member with no additional funding for the dependents that are also on the plan. PEB's timeline, which, sorry, doesn't show up very well up there. PEB's timeline has always been an issue between the timing of the legislature and the timing of when we need to get things done, at least for the first plan year of a new biennium. So typically in September, during that board meeting, we will bring ideas back to the board for any plan design changes, make our recommendations based on our research, and along with the help of our consultants and our other vendors to determine what might be a good offering, what we should include or shouldn't include. In November, the board must then make sure that they have voted on the final plan design so we can get ready for rate setting. During November and December, we look at what we need to do internally and with our vendors to ensure that we can offer the benefit design as the board approved. In January, any remaining decisions are made, and then between January and March, we start working on our plan documents. We also start rating our plans, so our consultants help with the rating of the plans. And then the March board meeting is where the rates are approved and any changes to our plan documents are approved at that meeting as well. Between April 1st and 15th, we load the rates. 15th to the 30th, we test those rates to make sure everything works. So we try to do various scenarios where, you know, we log into a training site and we will go in and change records to plus spouse, plus children, plus domestic partner to make sure that the rates actually change if somebody was to go in and change something or if they picked a different plan from what they do now. May 1st to the 31st is our open enrollment period. We typically use a full month. We have in the past cut that down to 2 weeks when there's some extenuating circumstances. That 2-week period is not ideal. It doesn't give members enough time to make sure that they get in and make any changes they want. If they don't want to make a change to their plans, they want to maintain the plan they currently have, they don't have to do anything. We don't do a positive open enrollment. We typically do a, you must make a decision that you want to change. That's been like that for a long time. We will do a positive open enrollment if for some reason all the plans changed, everything was going to change, and then we would need those members to make a choice. June 15th is the deadline for all the documents that we need back from members. So if they're adding any dependents, so spouse, we need marriage certificates, children, we need birth certificates, things of that nature. So if there's additional documentation, they have until the 15th to make sure they get that to us. And then between open enrollment and July 1st is when the behind-the-scene work gets done by our staff and our vendors to ensure that whatever changes have been made, if there are any questions that they need to reach out to the member about, they take care of that during that time. That is a very busy time for PEB. The whole team is on board and everybody's on phones trying to answer members' questions. So that gives you an idea of what we go through to make sure we meet our requirements by July 1st. So in building our budget, we make some assumptions and projections in order to decide what we need to do, where we are today, and where we're going to end up in the next biennium. One of those projections is enrollment. So on the screen now is the enrollment that we are projecting. So we are looking at about a 3% increase from fiscal year 25, which is a projected enrollment itself, and fiscal year 26, and then another 2.7% increase between 26 and 27. Part of this is being driven by vacancies being filled. So we're hoping that, one, the vacancies get filled because we need the staff, obviously. But as those positions are filled, that will drive enrollment up. Enrollment's been fairly flat, even decreased a little bit over a few years simply because we have experienced so many vacancies. The inflation that we use this was in consultation with our consultants. Medical claims the trend is looking at 5%. RX claims, my slide says 14%, but going back and reviewing the spreadsheet again, it should say 15%. We are seeing huge increases on pharmacy. Dental claims have stayed pretty stable over the years. It very rarely goes more than 3%. Typically, it's between 2.5% and 3%. And the HMO and EPO premiums, we have it set at 20% for two reasons. One, we blend the rates between those two, so the folks in the north and south pay the same premium, even though the overall cost is different. The contract for the HMO expires on June 30th of this year, so we did release a RFP. We're in the negotiation process for that HMO, and since we didn't know what the renewal rates were going to be, we used what was allowed in the current contract at the maximum levels because we don't know what the new numbers are going to come in at. The more critical thing to show over the percent inflation is the chart that you see here. This is actual spend out of PEB's budget for the state employees and retirees that are not on Medicare. So these are folks that are either on our self-funded, they're on all three of our self-funded plans. So in plan year 2022, we spent $210.9 million on medical and dental claims. Those are paid together. We paid $59.6 million on prescription drugs. But when you look at plan year 2024, that 210 went up to 241 million, and the prescription drugs went up to 89.4 million. That number is driven in part by an increase in our enrollment, but our increase in enrollment does not equal 49.9%. That is the cost of drugs. We have a lot of people on some very high-cost medications. And so for the most part, the plan picks up the majority. If those members are hitting their out-of-pocket maximum, then the plan may be picking up 100%. But we have folks on medications that are thousands of dollars a month. So that is driving the plan's cost. And then when you look at the total spend, when you compare 2022 to 2024, we're up 22.19%. So it is a significant drive. We have been operating in a deficit for the last 3 years. 23, 24, and now 25, we've had to do work programs to increase our budget authority so that we can continue to pay claims through the end of the year. And we're doing that by reaching into our reserve categories to do so, along with any savings we may have. The thing to understand about the inflation is if we're off with inflation inflation goes higher than what we budgeted for, and we're in the second year of the biennium, there's nothing we can do except reduce benefits or increase premiums to the members, because we have no way of increasing the employer contribution at that point. So we try to be really careful and conservative about our assumptions to ensure that we are budgeting at a level we think is appropriate to cover the costs that we need to cover without harming our members. And it's a pretty fine line to kind of try to balance on to make sure we're doing that. Our reserve levels, so we have 3 restricted reserves. Those are reserves we are required to have in order to backstop any expenditures we have. So you will see in 2024 and 2025, those are our budget reserves, $20 million for the HRA reserve. So that is approximately 80% of what the HRA balances are at the end of the year. That number has gone up to $29.2 million, and the reason for that, in part, is because of what we have funded on HRA reserves, including what excess reserves have funded in the past, in addition to additional funding that was provided during the last legislative session. So any balances those folks have, we need to make sure we keep a reserve in the event, for some reason, everybody made a run on their HRA, and for some reason we didn't have significant funding or authority in our categories to cover the HRA, we would go to this reserve. The IBNR reserve is incurred but not reported. That is for the runout and claims that occurred in the previous year that we pay in the subsequent year, or if for some reason PEB was to stop providing benefits and we were closing down the plan, some other decision was made, we would use what was in our budget plus what was left in the reserves to pay out any outstanding claims. The catastrophic reserve is our rate stabilization reserve, so that is where we will go if we're trying to mitigate or soften rate increases. So if we see double-digit increases and we want to try to, limit that to, if it's going up 10%, we want to try to make it 7.5%. We will use a portion of that money to help offset the members' premium cost. And excess reserve, so in 24 and 25, that's what was budgeted, but in fact, at the close of fiscal year 2023, we actually fully exhausted those reserves, so they don't exist. But in 26 and 27, we have excess reserves again, and that is not because PEB saved any money, because we haven't. We've been spending. But during the interim between agency request and GovRec, as they were balancing our budgets over at the governor's finance office, they were getting down to the wire of, do we try to adjust the funding side or do we pop it into reserves? And they opted to put the $2 million and the carryover, which makes it $4 million, in 2026 and 2027 into excess. Typically, when we make reserves in that category, it's because we've seen some savings or we've done some cuts to the benefit plan. And as I said, in 2023, we wiped out those reserves. And so to see this, it's a little bit of a safety mechanism for us if we should find a shortfall like we're experiencing this year. So those are all our assumptions. That's where we start in trying to determine what we think we're going to need in the budget. And this might be a good place to stop if there are questions before I move on.
You can go ahead and move on, and then we'll do all the questions at the end.
So now we go into the governor's recommended budget. What we're seeing is for the biennium, $1.5 billion, which is a significant increase over the previous biennium. You'll see that this pie chart tells you how our funding is broken down. We have carry forward in the amount of $88.8 million, and that is the beginning cash coming out of 2025 into 2026. That's a projection. We're hoping we're going to have that amount, but we don't know that that's accurate as of this point. The state pays a little over $440 million toward The employee and retirees benefits, non-state, they paid $22 million, and that's because that population is very small. And then the contributions from the members, that makes up the other 115 and 117 million respectively. And then all our other funding, so this would be our rebates, treasurer's interest, any other funding that might come into the plan from other sources, that's the other 46 million. That's an increase, significant increase, because we're seeing such high cost drugs. We're also getting higher rebates because we get all our rebates back, and we use that money to offset the member premium and the subsidies that are needed. In the medical plans, it is not fund mapped to any other expenditure within the plan. And this is the expenditure side. It tells you how we spend that $1.5 billion. So our operating is just over $7 million, just shy of $8 million in each year. That is our payroll. That is our operating costs. So computers, office supplies, if we need to buy a new chair, whatever, that is that amount. Self-funded admin, so we pay fees to our various vendors, our third-party administrator, our networks, in order to assist us with administering the plan. That equals about $17 million. Our HSA and HRA contributions, the $63 million. Self-funded claims, $412 million in the first year and $440 in the second. That's what we're projecting. The fully insured product, that is the HMO and our life insurance benefit, so that's sitting at between $68 million the first year and $82 in the second, and then our reserves make up the remaining. And you will see from the pie chart again, the operating costs are at 1%. That in the rest of the world is virtually unheard of. We have 34 staff when we are fully staffed, and so it keeps our operating costs down because payroll is typically the largest driver. But our payroll and our operating costs in all other areas are pretty much the same. So that's how we end up at $7 million. It's about 3.5 in salaries, and then the other 3.5 in everything else that's operating. So you can see that we do operate on a shoestring budget. Most of our money goes into our claims, as it should, and the pie chart demonstrates that. So in developing the budget, we came up with a few enhancements we thought was important to continue on, and a couple that are actual changes to the way we've done our budget in the past. So our E250 is the basic life insurance. That life insurance benefit was reduced in the last session, and the legislature funded the difference between our normal $25,000, which was going down, it was cutting it essentially in half. So we brought it back to the $25,000 and $12,500 for retirees. And to do that, we needed to add funding back into our budget, because typically we don't receive general funds unless the legislature decides to give us extra funding for something in particular. And last time it was life insurance and HSA and HRA contributions. E251 is a Medicare Part B subsidy. We're asking to increase that. Right now we give our members that are required to buy Part B that are on our self-funded or HMO plans, we require those individuals that are over 65 who are retirees to purchase Part B. And then we provide a subsidy toward the cost of Part B up until they hit a premium of 0. We don't refund them anything. We just try to take their premiums down to 0 or reduce it to some amount. We haven't increased that amount in a long time. We've been seeing the amount that the Part B costs. When we built the budget, it went up $9.80, so that's the number we use. It was just this made as much sense as anything else, so we opted to put that in there. Again, we don't necessarily give the member the entire 135, currently now requesting 145, if we've taken them down to 0. The E252 is a new enhancement for us. This is our medical RX dental inflation Typically, what we do is we have our assumptions for what we believe our inflation is going to be. The state then obviously looks at what they believe the statewide inflation is, and they will adjust our budget typically down because we see higher inflation. When you compare us to Medicaid or corrections, our inflation doesn't always fit. So what they've done this year is decide to take the difference between what the state was allowing, which was a little over 3.5%, and what we were projecting, and putting it in an enhancement decision unit. So that is where E252 comes from. It works out to approximately 7.5% of the total that, when you combine all three together. So this is E252. This is new, like I said, new for us, so we'll see how it works. And E253, so we have been hitting our reserves pretty hard over the last couple of years. And so we, in our M102, which is a maintenance decision, it's our in-house inflation for our reserves, and that adjusts our reserves up or down according to our projections, and that would be the three restricted reserves. We raised those reserves to get them back to a fully funded level. The governor's office asked if we could reconsider our reserve levels. Did they need to be that high? After discussing with them what we could do, we agreed upon the HRA reserve. We could come from 80 to 75% of the total, and the catastrophic reserve, we could use 45 days instead of 50 days. What ultimately ended up happening is they left the HRA reserve alone. They took our catastrophic from 50 to 45 days, and then we ended up with the excess reserves, which comes up and takes about half of it back. But in the process of making those changes, some reserves got increased a little higher than they needed to, so the E253 is taking them back to where they should be. So it's fully funding our reserves, except for the adjustments for the 50-day versus 45-day for catastrophic. We believe that this will, if this is fully funded the way we've requested in the budget at this point in time, that this will get us through to the next biennium. And this chart just gives you the dollar amounts behind the various enhancement decision units for 250, 51, 52, and 53. E300, that is an in-house request. We have, our staff are in cubes, and we have a couple of cubicles. We need to raise the walls on those just by virtue of their location, and they're on the phones with members talking about their personal information, so we want to give them a little more privacy by raising those cube walls. So E300 funds that. E710 is our typical computer replacement. E711, that equipment replacement is actually chairs and things. We've got a lot of old chairs. The chair I'm sitting in my office, I purchased when I was CFO, and that was a long time ago, but it's comfortable, so I keep sitting in it. When it falls apart, they can buy a new one. And the E720 is new equipment, so we've relocated from the Bryan Building over onto Gonai. We have a conference room in there that we use for training. We use it for meetings. They use it for interviews. And sometimes when we have the meetings in there, it may be meetings with our vendors. We don't really have a good setup for video conferencing or Teams meetings or such, so this will allow us to move in some equipment we would like so that we can make better use of that room. The next slide shows you the maintenance decision units, and that is typical for the state. So M100 is the statewide inflation that will cover like mailing going up, things like that we pay through the state. M101 is our medical and dental inflation. This is the amount that the GFO would allow for, and the difference from what our projection says and what they have is in E252. M102, that is the adjustment to our various restricted reserves. That's where we landed, and E253 actually makes the adjustment to that deck unit. M200 is our state enrollment, that's state employees and retirees, so that is our caseload. M201 is the non-state caseload, and M202 covers the Medicare caseload, and that is both state and non-state. We have right now about 14,000 members there, but we know the non-state population is reducing a little bit, as that door was closed in 2008, so they can't come back on the plan if their agency is not a participating organization. And then M300 is fringe benefit. This is the adjustment, one of the adjustments the state makes, and so wherever it lands, that's where it lands and ends up in our budget accordingly. The state participant subsidy levels, this chart shows you where we were in 24 and 25. That was the legislatively approved amounts. You can see how much it has increased for 26 and 27. This is driven by two things. That is the medical inflation, that E252 deck unit that that for the first time they've allowed us to keep in there, as well as recouping our reserves and getting them back to the fully funded levels we believe we need. And that shows you how big a difference that is between the two. It's strictly a number divided by the enrollment, divided by 12 months, and that's how that amount comes out. So things that we consider when we build the budget and when we decide on plan design and when we come before the various committees to talk about either policy changes or our budget, we look at plan design changes. So board-approved plan design changes, whether it's an enhancement or a reduction. We also look at legislative action. A lot of times when that action happens, it's too late to do anything in the biennium. So it could be mandated coverage, which typically year over year we see, new either services that need to be included that we aren't funded for, or we see additional medications that maybe weren't on the formulary that we need to add to the formulary. So any of those decisions that are made, if they take effect in the second year of the biennium, then we have to do our rates accordingly if we don't receive any additional funding. If a fiscal note is requested and we can calculate what we believe that might be, we will provide that information, but that doesn't necessarily mean that our budget is going to be adjusted accordingly. Timing of those decisions, obviously, and then funding provided or not to implement any new mandates. Those are all things we have to consider, and we look at that like, oh, this might happen. Like, we hear things all the time through the news and other sources to say, oh, we know there's probably a group of people that are going to come in and say, you should have your plans cover X, Y, Z. And sometimes it happens, sometimes it doesn't. But we do try to pay close attention to that so that we're prepared. We update our documents, and if we have to make any benefit changes, we do. Like I said earlier, if that causes the rates to go up and our subsidies don't offset it enough, and we don't cut benefits, then the difference is coming out of the member's pocket. And then finally, we have contracts that are expiring and that will be due to renew in 2026. The HMO is one of them, that we're in the process of negotiating terms on that one. Same thing with the Medicare exchange. I expect the Medicare exchange will be ready to go probably in the next couple of weeks. The HMO, we've been going back and forth on some terms, so I'm just trying to make sure we get that accurate. But those two will be in place starting July 1st. The contracts renewing in FY 2027, so we have a financial auditor, so we have an independent auditor comes in and does our financial statements. We have the dental network, that contract is expiring. The thing with that contract, we've had the same network for a long time. They just keep winning the bid. Their prices haven't changed a lot over the years, so If they change now, that wouldn't be surprising, but we've been paying, right around 68 cents per member per month for that network. And what we're doing is we're leasing the dental network. We don't own it. Our benefits management system, that is our enrollment eligibility system, that is a big lift. We have the RFP hopefully getting released this week. The contract expires December 31st, 2026, but we need an 18-month implementation window if we end up with a new vendor. So if the current vendor doesn't bid or loses the bid and we get a new vendor, we need an 18-month window. So that's why we're so far out on that one. The pharmacy benefits manager, that one is expiring in 2026. And so we'll need to make sure we get a new contract in place for that. And then our basic life insurance. That one isn't a heavy lift as far as the contract. We just want to make sure we're getting the best rate we can for our members. And with that, I'll take any questions.
Thank you so much for the very, very thorough presentation. I know that we do have a few questions for you. And we are going to start with Assemblymember Brown-May.
Thank you, Chair. Thank you for the presentation. I would like to start by saying I have a chair very similar that was new in 2007. Yes, so good work on the chair. I do have a couple of questions, and I know that you talked about it already, but I'm wondering if you can just provide additional clarity. Could you explain why participant premiums are budgeted to increase across all of the plans for state employees and state non-Medicare retirees? Can you just talk a little bit about that?
This is Celestina Glover for the record. So the rates increase based on what we're seeing in our own trend and experience. And then the consultants that we work with also look at what they're seeing for other similar plans, similar size plans, so typically other states and what they're doing. Because we're showing, as I showed in the one chart, how high our expenditures have gone over the last few years, that is driving that increase. So when we say we want to fund the plan, for this benefit structure, we determine what the medical inflation is going to be. So if we believe it's going to go up 5%, that it's not a one-for-one. It doesn't go up 5%. We look at all the moving pieces. So RX going up 15%, dental staying the same at 3%, assuming no changes in the benefits. So that's all the things we look at to determine where we should be. And then what percentage of that rate is funded by employer contribution and what percentage is funded by the employee's contribution.
Thank you. Follow-up, Chair.
Go ahead.
Thank you. So then, why is it that the HMO and EPO premiums are expected to increase more than the other plans in the 25-27 biennium?
This is Celestina Glover for the record. The HMO and the EPO plans are our most expensive plans. It's where probably the population with the most medical issues tend to go to because they are a copay plan. The HMO contract expires June 30th of this year. So we didn't know at the time we built this what the renewal was going to be. So what percent was going to come in. We know it's going to increase, but we didn't know, is it going to be 5%, 10%, 15%? The contract in place right now allows for a maximum of 20%. So that's the number we use because that is the max they could do. They could come in their renewals and say it's 25, and we'd be saying, nope, you can only go 20 because that's what the contract says. So that's where that number comes from.
Thank you. One more, Chair. Go ahead. Thank you. So, and I know you talked us through this a little bit, but just for clarity, can you explain the process and the time frame that the PEB board will follow in setting the rates, including the participant premiums for this next plan year 26 and plan 27?
Yes, this is Celestina Glover for the record. So back in September, we brought plan design ideas to the board, which our idea was don't change anything, leave it alone. We need to be stable for a while, and we tend to change things every year, so we were trying to avoid that. We, at the time, had made recommendation that the board consider actually eliminating the HMO and the EPO plans based on their cost and adjusting the low deductible plan so that it's structured in a payment level the same as HMO does now. And it's pretty close anyway. There was just a few tweaks we were going to need to make. The board decided not to do that for this go-round. They didn't know what was going to happen during the session, so they opted to push that to 2027. So after that decision was made in January, now we're in the process of setting those rates. So our consultants are going back, pulling our claims data, looking to see what everything looks like, taking the trend that we're projecting, and they are in the process of setting rates right now. Our next board meeting is March 20th, I believe, and that is when we will bring the rates forward for the board to review and approve. Typically, they do go with what the consultant gives them because, you know, if it costs $10, it costs $10. To say, no, only charge $9 is a problem. And charge $11, why are we going to charge too much? So typically, they go with that. The only other decision they'll make at that point is if the rates are going significantly higher, that they might want to offset that increase to the member using catastrophic reserves. Because we don't know how we're going to be funded in 2026, that would not be a recommendation I make at this point because we just don't know what that looks like. So we're in that process right now.
Thank you. Assembly Member Mosca.
Thank you, Chair, and thank you so much for this, as I'm still learning it all, but really appreciate your explanation. And my question was on the state contribution for the active employee group insurance. I see it's increasing to $991 in FY 2026, but decreasing to $943 in FY 2027, and just wanted to get some clarity on that.
This is Celestina Glover for the record. So whenever we make any changes to our budget, a big chunk of the funding comes from the employer contribution. So typically what we see is 90% of the rates are paid by an employer contribution. The remaining portion is paid by the member. When we built our budget with the inflation levels that we have right now and the increase to the reserves to get them back to fully funded, essentially what we said is here's all our funding sources, so rebates, whatever we have, and the difference is coming out of the contributions from the employee and the employer. That is where that number comes from, so whatever our budget looks like there, we're saying, okay, we need $1 million, divide that by the number of members, this is what it works out to per month.
Thank you, Chair. And I don't know if this is the same reasoning then, but my follow-up question is, why is the state contribution for non-Medicare retirees who retire with 15 years of service increasing to $650 in FY 2026 and $700 in FY 2027?
This is Celestina Glover for the record. The numbers I have are actually higher than that. Both of them are in the $1,000 range. Same reason. Because we take our employee and retiree, so we have two subsidies. We have AGIS, which is our active employee group insurance, and we have REGI, which is the retired employee group insurance. And we decide what amount goes toward each. So based on the plan, projected enrollment, whether they have dependents, because we also subsidize those dependents. Depending on the cost of the plan, that's where those numbers come from.
And you said that both of those numbers are higher, they're in the $1,000 range. Can you tell us exactly a more estimated $1,000 range, what that is?
So this is Celestina Glover for the record. I put the chart up on the screen. So we're looking at So we're looking at $1,022 for active employee insurance in the first year, and $1,007 for the retiree group, and then the $900 for the employees in the first year and the second year in the 2023 for the retirees. Once we set the final rates, which hopefully we'll have the end of this month, then we'll know if we can adjust those down if our consultants are seeing different numbers. But it is being driven by the inflation that we're seeing, and that is included in the budget for the first time, our full inflation projection instead of what the state typically uses, and the reserve levels being brought back up to their fully funded level. So that additional funding, that was a lot of dollars we needed to bring back into the budget, and so it's driving that up because that is the biggest portion of our funding is coming out of employer contributions.
Thank you for that. Next up, we'll have Assemblymember Anderson.
Thank you, Chair. Thank you for the presentation. So when I take a look, it looks like the governor's budget is adding $177 million over the 2025-27 biennium, and the new recommendation to fund that PEB-specific medical, pharmacy, and dental inflation. I want to say it was about slide 7, so I could be off on the slide numbers. And that would be in the M101 decision unit. Could you, though, explain the purpose of the E252 decision unit? And should the legislature expect to see this recommendation in the future?
This is Celestina Glover for the record. So on the screen right now is the M101 funding. We have $11.6 million in the first year and $28.4 in the second year. That is based on a 3.5% medical, dental, and RX inflation combined. So that is when they apply that to our budget, that's what that worked out to. This slide that's up on the screen now, so slide number 14, E252 is the $70.7 million in the first year and $106 in the second year. That's the inflation that we projected, so it's the difference between what we're projecting and what the state's projecting. The total of those two together is the total that we expect medical and dental to go up. A decision was made during the GovRec portion to attempt to allow PEB to have the portion of the inflation that they typically project to get into their budget. Because what has happened in the past, we say, oh, we need a 10% increase. And then by the time it gets to GovRec, they say, no, you only get 5%. And then the other 5% we have to figure out what to do with, which if we're correct, or if it comes up to some number higher than 5, even if it isn't 10, then we have to look, do we cut benefits or do we increase the employees' portion? Because that's all we can do at that point is increase their contribution.
Go ahead.
So I actually have 2 follow-ups. So first of all, should we continue to expect this, I guess, from the legislative point of view? That's number 1. But then, actually, why don't you answer that first question, if I may, with indulgence of the chair.
This is Celestina Glover for the record. My understanding is this is a way to demonstrate the difference between state inflation. So they combine what Medicaid sees, what corrections sees, and what we see. Corrections is definitely a different structure for their medical benefits than the state employee benefits. So they have probably more mechanisms in place to save money. They have medical staff that they can go to, as well as going to the local hospitals or whatever, where we don't have that. My understanding is we will go forward doing this way so we can see the difference between the two. I don't know if in the future they'll just say, okay, PEB will go with whatever your inflation projections are and leave it that way and it'll go back to M101, or if we're going to keep splitting the difference between what the state typically sees and what PEB projects.
Thank you. So it sounds like there are some departments that do have something, but really it feels like, based upon your answer, that this has a little bit more to do with how GovRec handles it. Okay, seeing you shake your head yes or no, that's what it feels like. So I'm going to move on to the next one. So my other follow-up, you're basically trying to do a crystal ball right now. And because of that, what happens if it's actually less then what you are presenting to us today, does that mean you come back to IFC, or does that mean like, woo, it's less than we thought it was, or we're not going to go if it's more, let's go with less? How do you handle that, and how do you report that to this body?
So this is Celestina Glover for the record. So what has happened in the past, and my crystal ball says we'll do it the same way going forward, is if we say we need a 10% increase, it comes in at 8%, any savings that we generate goes into excess reserves. We'll use those excess reserves to offset either premium increases if we see additional premium increases, or to maybe fund additional HSA and HRA money, or add benefits to the plan. Typically, if we are tapping into excess reserves, we do come to IFC to say, oh, look, we're going to pay life insurance premiums, we're going to raise life insurance, whatever it is, and we're going to use excess reserves to do it. Otherwise, it just sits there until the next biennium when we come back with budget, and then anything that we can fund through the excess reserves to drop the reserves down if they should go up significantly. If we can drop them down, and then the difference will reduce the amount of funding we ask for other sources by offsetting it with the excess.
Thank you, Chair.
Thank you. Assemblymember Backus.
Thank you so much, Madam Chair, and hopefully I can have two questions, because I wanted to follow up on my colleague's question regarding the excess reserves. Looking at, I believe it was slide 9, wherein you had indicated that looking at this fiscal year, you weren't really sure. My question would be, is how much of this reserves do you think may be exhausted in this fiscal year?
This is Celestina Glover for the record. So the excess reserves, we have none. So the amounts on that slide, let me get back to it. The amount on this was the legislatively approved levels, but we had to use them up in 2023. So those we don't have. We have tapped into catastrophic reserve, IBNR, and the HRA reserve just during the balance forward, because the amount of money coming in to pay for our cost are not enough. So we typically get funded a certain dollar amount, or approved a certain dollar amount that we're going to balance forward year over year, and that number hasn't come in. We had a $26 million deficit from 23 to 24, and a $43 million deficit from 24 to 25. So the only place, we have a couple of places we can reduce. We can reduce our expenditure categories, which there's not really anywhere to go except claims, and that doesn't work because we know we're spending more than our authority. Or we can reduce the funding GLs, but whatever funding comes in, then we just have to do a work program to raise them again. So the difference is coming out of our reserves, that we made a decision internally to say, okay, we need to adjust the budget by 40 million. We're going to tap into reserves and reduce those reserve levels to account for that.
Thank you for that. And then kind of changing topics, looking back at the increases to the participant premiums and the state's contributions to fund the increased medical, pharmacy, and dental trend as recommended by PEB's actuary. My question is, can you dive in a little more on how does the actuary determine the inflation? And I know that was like, I think I had my slide highlighted where it was the 5%, which dental, I guess, is now, not dental, I'm sorry. One of the other percentages changed from 14 to 15%. And then also really curious about how the actuary looks into that utilization increase of claims.
So this is Celestina Glover for the record. So our actuaries get claims data from our third-party administrator and from our pharmacy benefits administrator to look and see what we are spending on claims for the various groups, so state, non-state, retiree, employee, also by plan. And they're looking at that to see what kind of trends is actually happening within our benefit structure. So are the costs going up? Are they going down? Are they staying the same? Then they also look at what is happening across the nation in their book of business and with other colleagues where they can get the data, whatever data is readily available, and they look and see what is happening in that world. As far as we can see in everybody's world, everything's going up. It's not getting less expensive. So we are seeing that inflation. Based on what they're seeing and what they believe is going to happen, again, the crystal ball, on where we think PEB is going to be, they do feel like it's going to normalize, but it's normalizing at a higher rate. So that's where these numbers come in, and that is what is driving our costs. So if ultimately what this works out to is the overall rate goes up 10%, what portion is the state paying and what portion is the employee paying, that is where the difference is. And typically the state pays right around 92% of that, and the employee pays the other 8%. So that is how we get to that number. So when we see rates for this year, like I said, we hopefully will see them the end of this month, first part of March. We'll know what those increases look like. What I can tell you last year for the HMO, for the plan year we're currently in, the numbers supported a 28% increase, and they came in at 12.5% increase, so we saw double digits there. Our numbers came in a little bit less than that for the self-funded plans, but we also, we operate on a much tighter budget than the HMOs do. And so even though we saw an increase, our increase was still pretty significant. We were still looking at 9% for the self-funded plans, and we don't really see that changing when you take all of the claims we pay, medical, dental, and prescription drug. We don't see that coming down significantly. I will hope that it stabilizes and we don't see any bigger increases than we're expecting, but I don't see it going down, at least not in the near future. Maybe in the distant future, but not right now.
Assemblymember O'Neill.
Thank you, Chair. I appreciate the time. Ms. Glover, I really want to thank you and your team for coming in today and sharing St. Valentine's Day with us. And I appreciate your position with PEB, because I know it's probably one of the more difficult programs in our state benefits to really manage. And as you're saying, the crystal ball that you need. I don't think inflation is going to be going down anytime in the near future, even in the somewhat foreseeable future on medical, dental costs, et cetera. But with that said, and also for full transparency, I want to let you know I am the assemblyman for District 40, which includes all of Carson City, the state capital with numerous state employees in it. I'm also on the board of directors for Carson Tahoe Hospital. And last but not least, I'm a retired employee who had to buy his chair. And then when I retired, I left it to the new division chief to have, because it was much more comfortable than what was being offered. I'm receiving emails and phone calls regularly, even more so, it seems each day they're increasing, about United Healthcare's policy with state employees, and that Carson Tahoe will not be accepting those state employees on United Healthcare come the first of the fiscal year. Can you give me any insight, A, what PEB is doing, and if you have a contingency plan if CTH, United Health, and PEB are unable to come to an agreement for our state employees?
This is Celestina Glover for the record. Want to guess how many times I've been asked that? A lot. So myself, United Healthcare, Carson Tahoe, the governor's office, we have all been in multiple meetings. We've had all the parties in the room together. I've been in meetings with United Healthcare without Carson Tahoe. I've been in meetings with Carson Tahoe without United Healthcare, so I can kind of get feedback from both sides. because they're not necessarily going to be real open with what they want to say when the other party's in the room. We have done everything we can to try to get the parties to talk and to come to an agreement. Carson Tahoe has made a decision that they're not willing to continue to work with United Healthcare. However, they did tell me that they would be willing to extend the existing contract to the end of the calendar year. And my understanding is the two parties are trying to come to terms. I got an update a couple of weeks ago, but I haven't had a recent update. We aren't party to that contract, so we don't know what those terms are. It's confidential. So we're not, the contract's not with PEB directly, so that puts us in kind of a disadvantage based on whatever either party wants to tell us. In the meantime, what we are doing is we are releasing an RFP, hopefully this week being next week, to get a secondary network that Carson Tahoe will be in, because there's no point bidding if they don't have Carson Tahoe. We will run two networks side by side, one that has Carson Tahoe in it and the United Healthcare network separate until that contract expires, which is in 2028. And then that will keep our members able to access Carson Tahoe, because it's not just Carson City. We have people that live in Reno that work in Carson, and their providers are here. Douglas County, the same thing. I live in Douglas County, my provider is here. So, you know, it affects all of us in one way or another. So we are working on that. We've been working on the RFP to make sure we have something in place. What we also believe is going to happen with the secondary network is there's the potential we might pick up a couple of providers that weren't in the network to start with, that maybe they will be now because it is a different vendor. And so maybe it'll open up a little bit more access to various providers in the area. And we have asked that network be statewide. So it's not just going to be providers up here. It will get Carson Tahoe, but if there are some doctors down in the south or other medical providers down in the south that are on that contract that aren't on UHC right now, that could open up some access to those members. We won't know until we get bids back from the various vendors what those provider lists will look like. So we'll know who's in and out of network with theirs, and we'll have both at the same time. So we're working on it.
May I have a short follow-up, Chair? Thank you. So just to clarify too, because I respond to my constituents, if you do, the RFP goes out, you do go with a second or a new insurance provider for them, UHC does not extend at all. So the state employees, those employees using United Healthcare could leave, go to the new insurance company, if I understand correctly, without any penalties or costs for them to leave United Health and going over. I just want to make sure I provide the proper information in my responses. And I'll ship most of them to you probably.
So this is Celestina Glover for the record. They are not leaving an insurance to go to one provider or the other. Technically, we are the insurance, PEB is, so they're a PEB member. The network is leased by PEB through whoever the network vendor is, and we provide that access to our members so they can go to the provider, and in this case, that's in either network. So United Healthcare will be the primary for all the providers if they're in both. United Healthcare is our primary until that contract expires. It's any new providers that maybe aren't already in United Healthcare and of course Carson Tahoe. So for the member, they will go, their member cards will say what the networks are so that when they do go to a provider, that provider will know who to bill. So it for the member themselves, other than determining if the provider they want to go to is in network, which they can check on PEB's website or call PEB or call UMR, nothing will change for them other than giving them that access.
Thank you. Thank you, Chair, for the time. I appreciate it.
You're welcome. Assemblymember Hafen.
Thank you, Madam Chair. Actually, my question was answered. Thank you.
Perfect. Senator Stone.
Thank you, Madam Chair, and thank you for the presentation. Happy Valentine's Day. According to your actuarials, when you're looking at medical, pharmacy, and dental, pharmacy seems to take the cake at 15%. We see the rising cost of pharmaceuticals. Also saw in your contracts that you're going to be renewing a pharmacy benefit manager. Can you tell us what the magnitude of prescription rebates has been with the existing pharmacy benefit manager is, number one? And number two, as you put out that RFP for a pharmacy benefits manager, who's designing the formulary? Does one pharmacy benefit manager give you one formulary versus another? Because the way you're going to control costs is through that formulary and through the rebates. And with an increase in the number of new biologics, weight loss drugs, diabetic drugs, there's room for competition and pitting one company against another to derive more rebates. Can you tell me how that factors into the RFP process? So,
This is Celestina Glover for the record. So we will work with our consultant to help us write an RFP that will outline everything PEB needs in their pharmacy benefits manager. The bids will come in. Obviously, we will have an evaluation committee that will look at those, and we will have the costs related to those and what is covered by the various bidders. That will be analyzed to determine which one is giving us the best bang for our buck, and that'll be ideally the winning vendor. As far as rebates go, PEB has always had in their contracts that they get 100% of the rebates on whatever drugs are eligible. So that money has always come to us. Years ago, we were getting $9, $10, $11, $12 million a year in rebates, and the rebates are about a 6-month window behind the actual claim. Our projection, based on cost and what we're seeing right now for 26 and 27, that's going to be in the $40 million range. We are seeing right now anywhere from $22 to $25 million annually in those rebates. So based on that, we are expecting that to come higher. We take that and fund map it. So we map those costs strictly to the self-funded plans because that's where those costs are being generated. The HMO has their own rebate structure, which they don't share with us, so we don't know
Right.
what that looks like.
thank you.
Senator Titus.
Thank you, Madam Chair. Thank you, folks, for being here today. I have a question along the same line as my colleague that represents Carson City. I represent rural areas. I have many state employees that have retired or going to retire or are still working, and I too get a lot of emails regarding this situation, and it's not as simple as you make it out to be. I'm worried about that RFP that you're sending out. These folks cannot access care, period. It may be okay if you live in Carson City that you can go up to Reno, but I can tell you if you live in my rural area, you just cannot, there's no alternate options for them in this very narrow provider list that you offer. And my question is on this RFP that you're putting out now, are you making sure that one of the requirements is that they have to have access to your PEB folks throughout the state versus just north-south, as you referred to? And I'll go there, and then I have another question.
This is Celestina Glover for the record. We look at a demographic metric to determine where our members are located and where the providers are located. We do our best to try and make sure that we have providers in all the areas. We do know that there are pockets in Nevada, especially as spread out as we are, where there are, one, no providers to start with, or they're not in the network. the ultimate decision of the provider in the network is whether or not the provider wants to work with that network. But what we do is when we have someone that needs care and there are no networked providers, or there's a specialty that's just, not accessed very often, we will try to work with that individual provider to come to some agreement so that we can make sure that the amount we're paying the provider is fair for the provider, but whatever portion that the member has to pay outside of what the plan pays, that's also reasonable. We do that on a fairly regular basis where we have one-off agreements to get the care that that individual needs. And that's case by case because obviously we want to make sure that the provider's in the network. We will also reach out, UMR does this on a regular basis, reach out and see if they can't convince the provider to come into network so that people can access that. Obviously, we can't make them join the network, but we can ask and hopefully they will agree and that the terms will be reasonable for both sides. So it's not that we're not considering, so when I say north and south, to me, the north is all the rurals and us up here. The south, Clark County is the biggest portion in the south, so I kind of look at them on their own because their dynamic is different than it is up here, than it is in eastern Nevada. We do have a lot of providers out in those other areas when you start heading out toward Fallon or Elko and places in between. It's just a matter of whether or not that particular area has a provider and is that provider willing to be in network. Some are not, and it doesn't matter if it's United Healthcare or Aetna or some other network. Sometimes they just prefer not to join those networks, and then we'll try to work with some sort of billing in that case that we can both agree on.
Well, that sounded great, but in reality, that's not what happens. So folks, when you sign up with a sole provider, United, and they offer, well, you have to sign up with us, here's what we're offering, and it's a ridiculous contract that they want the provider to then sign, and the provider says, no, I can't do it for that. You're saying, well, we offered, but the provider didn't want to work with us. I think that just is very superficial, what really attacks the real issue. Yes, there's many areas that don't have providers, but I can tell you where there are providers, the providers can't afford to go onto these programs that don't cover their cost. And then the patient has no care. Do you make any exceptions, and have you thought of allowing, if there is no providers and X number of miles that are on this program, that the employees can go to the provider of their choice? I just think that the way it's laid out offers local hospitals, rural areas, rural providers to say, I can't do it for that. And then you're leaving your people uncovered, and then you make it sound, well, we offered it to them and they just can't take it. Do you have any avenue where it can be like a fee-for-service out in the rural areas?
This is Celestina Glover for the record. We don't have anything like that in place right now. Obviously, we would need to go out and contract for that because PEB doesn't have the expertise or the staff on board to take that in. That is something we can take back to the board and look at if that's an option. But like I said, it's not that, I don't want to come across sounding like we did what we can and they just don't want to join. That is not my intent. What I'm saying is that we do what we can to try to get as many providers in the network as possible. I understand that there may be issues with the payment levels the various networks will pay, what they agree to. We don't know what the terms of those contracts are, and we don't know, like providers aren't telling us that. Like they're not saying, oh, I'm getting paid $5, I should be getting paid $10. I'm not getting that information, probably because the contract is confidential on both sides, so I don't know that they can share that information with me. But we try to make sure we're doing whatever we can within our own power to try to get as many providers on board as possible to try to address the areas where either we have no providers or very few providers, or that those providers are not in the network. We do, like I said, try to sign one-off agreements when we need to get somebody on board for care for an individual, whether it's in a particular area or in a particular specialty, or, you know, a situation of care that maybe is for a finite period of time. They just need to get through these treatments. Whatever it may be, we do what we can, we analyze what we can, but you know, in the long run, we are going to have cases where we don't have those providers in network. We can only talk to them, work with our network. Hopefully with the secondary network coming online, that may pick up some of the providers that already contracted with them that maybe our members don't have access to right now. Until we get those bids back, we don't know what that looks like. So as soon as we start seeing those bids and we can see what providers are out there, then we'll have a better idea. And we do require that we have providers within a certain distance, and if they're not available, then we do allow for access to other providers.
Final question, Madam Chair, I promise. In your RFP, did you demand that whatever provider you choose has to have access throughout the state, not just north-south? That there has to be a definite bridge that for access?
This is Celestina Glover for the record, yes.
Okay, so, and that's a public document that we can look at? All right, thank you. Thank you, Madam Chair.
Thank you. Senator Neal.
Thank you, Madam Chair. I guess there's a level of confusion I have about UMR and UMR as a third-party administrator. So here's why I'm not clear, right? So in the summer, I had to get involved with trying to figure out who UMR is, because they have a relationship to some police contracts down south. And then when I reached out to the Division of Insurance, I found out that UMR is owned by United Healthcare. So tell me how they're your third-party administrator and contracting, and they're owned by United Health.
So this is Celestina Glover for the record. So when the RFPs were released a few years ago to get a third-party administrator, it was time to go out to bid. UMR was the winning vendor. At that time, we had a different network, and a decision was made to bring on the United Healthcare network in relation with the third-party administrator. I wasn't part of those discussions, so I don't know for sure what drove that decision, but that's ultimately what it was. I wasn't here at that time, so that's why I wasn't part of the discussion. It wasn't that I was left out, it just, I wasn't here at the time. So I'm not sure what those discussions might have been, why that decision was made, but at the time, that was the direction that PEB and the board went. I'm not married to keeping United Healthcare as the network going forward when we go out to bid. We want to get the best network, the most access, and make sure that our members can get the care they need in the locations that they live. So that is our ultimate goal.
Madam Chair, follow-up. I guess maybe I'm not saying this right. Okay, this is what I'm not clear about. What the role of the third-party administrator is to be a neutral party?
This is Celestina Glover for the record. United Healthcare provides our network, so that's where we get our providers. UMR is our third-party administrator. They adjudicate claims and pay those claims according to what is allowed on our benefit structure and whatever the network contract between United Healthcare in this case and the provider is. So if the agreement is you're going in for knee surgery and United Healthcare contracts with a provider that can do the knee surgeries, we have it covered on our plan. the third-party administrator will adjudicate the claim and pay that claim according to whatever that agreement is over here. They're not a party to that agreement.
Okay, that's great. Because, so the UMR is adjudicating the claim, but I think the thing that's missing in this conversation that I'm trying to insert into this conversation is that UMR is owned by United Health. There is no wall because United Health is providing the services and then UMR is adjudicating a claim that they may or may not have, I guess, covered, but they are owned by the same company. So where is the transparency? Because I remember you saying that you couldn't see the contracts, so you couldn't really negotiate it, but your third-party administrator is owned by who you're in a contract with. See the weirdness? See the like you're being, I'm not even gonna do one of my terms today, but it's being hustled. So I'm trying to process that because I had a question on your increase in the dental claims, but then I got stuck on the fact that UMR and United Health are pretty much one and the same because they're owned, is only one owner.
This is Celestina Glover for the record. So when the TPA pays the claims are based on, the benefit is based on what we have in our plan, what we say we cover. So if we say we cover 80% of, the knee surgery, then the difference is what the network has agreed with the provider on what they will accept in payment for that knee surgery. So there is I don't even know how to phrase it, there is a wall, so to speak, where the TPA, the third-party administrator, isn't a party to the contract between United Healthcare and the provider. How they keep that separate, that's an internal process that I can't answer for. I can see if they are willing to share that information. But from the claim itself, the dollar amount is based on whatever the agreement over here is, but what they pay is based on what our benefit structure is. So if we cover it, it's paid, but the rate is determined based on what the network rate is that they've agreed to. And I know there are multiple contracts. Even with a single network, they can have multiple contracts for various providers where they pay one provider one thing and another provider something else for the same service. I do know that happens. Why that is, I don't know. It's what they present and what they agree to. But the claim itself, if it is a benefit we cover, then the third-party administrator will make the payment on that. It's just how much are they paying out, and that's based on that network agreement. So how they keep a separation internally, I can't answer for that.
Thank you, Madam Chair.
Thank you. And there's one thing that we didn't talk about today. There's a conversation of PEB being rolled into the Nevada Health Authority. Can you tell me, have you guys thought about how or what changes might happen to PEB if that were to happen?
So this is Celestina Glover for the record. When we built our budget, we weren't aware of the Nevada Health Authority. There were some discussions over the year and a half, 2 years that I've been back with the state, but nothing was set in stone at that point in time. We were made aware of it right as GovRec was happening, that they were going to move forward. My understanding from the few conversations I have had is that, at least for the current biennium, PEB will come under their authority as an organizational structure, but the way we do business right now with the board and our benefit structure and all of that will not change. But what it may give us access to is some of the expertise we don't have on staff through their data analytics and some of their contractors, and potentially getting better options for whether it's a network, pharmacy, all of these other costs that really drive the cost of our plan up. So we don't know what that looks like yet until we can get some more detail behind it. I haven't seen the language in the bill that's coming forth. I've been listening to the hearings, but I haven't seen that final language myself, so I don't know if there's anything else anticipated.
Thank you. I think we're all looking forward to seeing that language. And as we move forward, if you see anything in that language that is of concern, I'd appreciate it if we can have a conversation to make sure we work all those things out before we close the session out.
This is Celestina Glover for the record. I will reach out to staff and ask for a meeting.
Thank you so much. So seeing no other questions, I thank you so much for being here today and for the presentations. And members, thank you for your questions. And that brings us up to the last item on our agenda for today, and that is public comment. We'll ask if there's anyone here in Carson City that would like to make public comment to go in and fill in all the chairs. If there's anyone in Las Vegas, feel free to fill in the chairs there. We will be limiting public comment to not more than 2 minutes, and there will be a timer on, so please don't think I'm rude when I step in and say thank you. If you are not able to finish your comments in the 2 minutes, I ask that you submit them in writing if you have not done so already. And again, if you'd like to call in for public comment, the number is 888-475-4499, and today's meeting ID is 891-9671-8663, and then press pound. We'll start here in Carson City, go to Las Vegas, and then to our phone lines. You can go ahead as soon as you're ready.
Thank you, and good morning, Chair Monroe Moreno and Dondero Loop and committee members. My name for the record is Terry Laird. I'm the Executive Director at RPEN, the Retired Public Employees of Nevada. We have lobbied to protect the pensions and health care benefits for all public employees, actives, and retirees for nearly 50 years, and we have nearly 7,000 dues-paying members in 17 chapters statewide, and we are a non-profit, nonpartisan organization. I'm happy to hear that the Nevada Health Authority was mentioned. I thought that I was crazy seeing that on the agenda this morning. But we are concerned about such a change because our members are concerned and they depend on reliable and stability in their health care. And we're concerned about what that sort of change might mean for them. I can speak from my years with RPEN since 2009. There have been a lot of changes happening with PEB, and some of them not so great, some of them good. But we would like to see that stability continue, and therefore we look forward, as well as you, to hear what's going on with this Nevada Health Authority and how it may impact our members. Thank you.
Thank you.
Good morning, Chair and members of the committee. Tess Opferman for the record here on behalf of the AFSCME retirees, Chapter 4041. I've got a few things to say, so I'll try to be as brief as possible. First, I just want to say thank you to PEB. They have been excellent to work with. I go to many PEB meetings. I appreciate the PEB board. And Celestina Glover is incredibly great to work with. She's responsive. She responds to emails, and she's worked with our AFSCME retirees. So on that front, I want to give my appreciation to PEB. I also want to say thank you to this body. We were able to, or at least we're attempting to restore the life insurance benefits. I know this body funded those in the last biennium at the last legislative session, and those are now in the proposed budget. So thank you on both those fronts. I do know, obviously, a lot of this conversation has to do with providers and plans and ensuring that actives have access to doctors, and that's critical. So I understand why that is the focus of this conversation. That said, I do want to circle back to something that I talk about, I think, in front of this body regularly, which is the HRA reimbursement rate. So for a super brief history, in 2011, the legislature decided to move state retirees to the state plan for Medicare. These state employees had been guaranteed health care coverage through retirement, and many of these employees accepted lower wages in exchange for this promised benefit. During the 2011 change to Medicare, the health reimbursement arrangement was created to cover retiree out-of-pocket expenses. Rather than giving full health care coverage, retirees would be covered by Medicare, and in addition, out-of-pocket costs could be covered by the HRA. Unfortunately, this promise of health care coverage is not being upheld today. Despite a health care cost increase, the HRA has only increased one time in the last 14 years. We did survey our members this past fall to get a better sense of their health care costs. On average, they are receiving $244 through their HRA, but their monthly healthcare costs are about $335. I want to just highlight one quote from a respondent. She said, "Our premiums keep going up every year, but the reimbursement of $260 hasn't at all." She worked for the state of Nevada for 30 years and receives the maximum HRA of $260. However, between Medicare Part B, her supplemental plan, dental, prescription drugs, she is spending a total of $550 a month on her Medicare coverage, on her medical costs. This means she's paying about $290 out of pocket monthly. We cannot continue to push this can down the road. Every year we know healthcare costs increase, but the HRA is not increasing. Thank you so much for your time today.
Thank you.
Good morning and happy Valentine's Day. Kent Irvin, ERVIN, Nevada Faculty Alliance. For the record, my office chair when I started UNR in 1990 wobbled and had duct tape on the arms. It didn't get replaced until after I earned tenure, and that new chair had to last until my retirement in 2023. The new chairs in this building are great, so thank you. Thank you for your consideration of state employee health benefits, which are very important for recruitment and retention. Ditto to Ms. Laird and Ms. Opperman. We are pleased that we are looking at stable plan benefits for the public employee health benefits for the next biennium. However, we still have not fully recovered from the benefits cuts during the pandemic. PEB eliminated long-term disability insurance, and employee premiums are significantly higher than pre-pandemic. There is a steep increase in the per participant state contribution in GovRec. However, this value has been kept artificially low for years. It hovered around $700 per active employee per month from FY 2014 to FY 2017, and then only up to $759 in FY 2025. That's a much lower increase than healthcare inflation. The result has been cuts to benefits over the years, and now reserves falling well below the actuarial mandatory reserves levels. An issue regarding networks is that state purchasing requirements favor networks that promise lower costs. Lower costs means lower payments to providers. While we wait to hear more about the Nevada Health Authority proposal, we are concerned about bringing PEB into a larger bureaucracy. The goals of employee benefits are very different from Medicaid and the state insurance exchange. In most enterprises, employee health insurance resides within a human resources or benefits department. Thank you.
Thank you.
Doug Unger, D-O-U-G, U-N-G-E-R, Nevada Faculty Alliance, and I'm also, for many years, a member of the UNLV Employee Benefits Advisory Committee. I wish to, for the record, thank PEB Executive Officer Celestina Glover for her hard work and dedication for many decades to the state and her steady stewardship of PEB. We appreciate the deep knowledge and wisdom she brings to her leadership of this all-important state agency on which our health and so a good portion of our happiness depends. Thank you, Executive Officer Glover. I would also like to respond to Senator Titus's and Senator Neal's bringing up of an important issue, which I deal with as a member of the UNLV Benefits Advisory Committee all the time, which is that the United Healthcare UMR, which has achieved nearly monopoly control over the provider networks in Nevada, continually pay providers less, and then are continuing to deny coverage, at least initially. There's an initial denial that's happening to our employees that they then have to appeal, and then they get paid. The claims get paid. So that employees are being squeezed and providers are being squeezed from both ends. Lower payments to the providers and more denied claims to our employees. This is a larger issue that's a national issue and a state issue that I'm unsure how leadership should address, but it is the most important issue in healthcare in Nevada. With behavioral healthcare in particular, we have more than half of our behavioral healthcare providers in Southern Nevada that no longer take any insurance at all. They just do cash. So thank you for addressing that issue and really thinking deeply about that issue going forward. Thank you.
Thank you. Not seeing anyone else for public comment here in Carson City, and not seeing anyone at the table in Las Vegas. AVHU, do we have anyone joining us on the phone line that would like to make public comment?
Thank you, Chair. The public lines are open and working, but we don't have any callers to provide comment at this time.
Thank you so much. So members, some of us, well, all of us had a snow day yesterday, but some of us were assigned to some subcommittee meetings, and to make sure we do not get behind, we are going to make up those meetings today. So take about a 15, 20-minute break. If you can be in the chairs for your subcommittee meeting no later than, let's say, 10:15, would be wonderful. And with that, this meeting is adjourned.